As I said, we're absolutely delighted to be with you because having travelled from Manchester, I don't know if anyone's come from the northwest, you'll know that you have to come from junction 20 of the M6, and I was really worried. Last night I was having nightmares about this. I thought I'm going to be ringing Helen and Carla saying, look, I'm really sorry, I'm on the M6. I can do some sort of remote presentation. But anyway, I'm delighted to be here. I've got here, which is great. So the plan for today's talk is I wanted to go through a little bit about psoriatic arthritis. Obviously, I'm a dermatologist, so I'm not a joint specialist, but I can give you the perspective of a dermatologist. How we might screen for psoriatic arthritis and some of the treatments that we might use for that. But importantly, I wanted to focus on a service that we've set up in Salford Royal Hospital, where we do a combined clinic with a dermatologist and a rheumatologist. I was also asked to give a few research updates on BADBIR and then something called PSORT, which I'll explain more about later. And then I've had a reasonably big publication in a journal called The Lancet this year on a drug called Methotrexate. So I also wanted to share a little bit of data on that for you as well. So in terms of psoriatic arthritis, I don't want to revisit old ground that Effie might have touched upon. But this is well, you understand the genetics now, don't you? Because Effie's taken you through it. So it's what we call a complex genetic disorder. So you have a genetic risk, and then certain environmental things come along, and then people will express the condition. The male to female ratio is roughly 1:1. Psoriasis occurs in 2 to 3% of the population, and psoriatic arthritis affects anywhere between 5 and 20% of patients who get psoriasis. And interestingly, the severity of the psoriasis itself does not necessarily link in with the severity of the arthritis if an individual develops that. Now, this is a graph looking at the prevalence of psoriatic arthritis in psoriasis patients. And you can see that depending on which study, there's anywhere as low as 5 up to much higher results. And I quoted you somewhere between 10 and 20%. And I think the reason for this variation between these studies is simply that if you take a population of people in primary care, psoriatic arthritis isn't as common. If you take a population of people being managed in a secondary care dermatology centre, so they have more severe psoriasis and there's more of them clustered there, then we tend to be better at detecting the psoriatic arthritis. So that probably explains some of the variation. Psoriatic arthritis is an inflammatory process, so you can get different types of inflammation. If you think the Achilles tendon is the biggest tendon we've got, and if you track down your calf and you feel your Achilles, you can feel where it goes into the bony bit, and that's the tendon insertion. And one of the hallmarks of psoriatic arthritis is that tendons and ligaments, where they insert, you get inflammation, and we call that, the medical term is known as enthesitis. And that's one of the hallmarks of psoriatic arthritis. You can get inflammation of the joints, called synovitis. That's very common with rheumatoid arthritis, a little less common with psoriatic arthritis. And then psoriatic arthritis can sometimes involve the spine, and that's a term that we call sacroiliitis. There's another term that we use a lot, and Dactyl Itis. Now, this is an individual's toe who has Dactyl Itis, and what that means is if you imagine down the side of your fingers or down the side of your toes, you've got tendons that leap from the little bones between them, and if those tendons get inflamed all the way down, an enthesitis all the way down, then we refer to it as a dactylitis. And again, that's a common thing, but as a dermatologist, if someone comes in with a skin complaint and we don't remove their footwear, and the person doesn't think, I've got a sore toe, that's linked to my skin, it can easily be missed. Fortunately, X-ray changes in psoriatic arthritis, even to the untrained eye, you can see that that bone should fit neatly and squared off like that, rather than losing what we call, when you lose bone, you get osteolysis. Fortunately, these appearances are now very rare because anybody who has a more aggressive type of psoriatic arthritis quickly is offered a more effective type of treatment, whether that be a systemic treatment or a biologic treatment, such that we don't tend to see, fortunately, the X-ray changes anywhere as frequently as we used to. But this is a really, really important slide and is the most important background slide I'm giving you today when arguing that the kind of service we run in Manchester is important and needed. So this was a colleague of mine, Christian Reich, who I've worked with a lot, and Christian is a very, very vigorous dermatologist in Hamburg, great guy. And Christian looked at the incidence of undiagnosed psoriatic arthritis in a cohort of psoriasis patients across Europe, 1,500 patients. And what they did was they all got assessed by a rheumatologist, and they found that there was 20% of people who didn't know they had psoriatic arthritis or that their joint aches, pains, etc. were linked to their psoriasis. So the vast majority of these were newly diagnosed, and actually quite a number of people had quite a lot of involvement in terms of over 5 joints affected. So you could argue, well, does it matter if they're seeing the dermatologist and they've got potentially the psoriasis is quite bad? Would a treatment for the psoriasis help the arthritis? Of course, a topical treatment, unfortunately, can't help the arthritis. And phototherapy, unfortunately, can't help the arthritis. But do some of the other medicines that are used for treating either psoriasis or psoriatic arthritis help the arthritis? Methotrexate probably does help psoriatic arthritis. But you can see here, sulfasalazine, which is a drug people are given for arthritis, does nothing for the psoriasis. Hydroxychloroquine, a drug given for psoriatic arthritis, does nothing for psoriasis. Cyclosporin, a drug given in the short term for psoriasis, doesn't do very much for psoriatic arthritis. So missing those cases, it's not going to be covered by then being on the right treatment, almost by chance, if you like. So this has led people, including a colleague of mine, Chris Griffiths in Manchester, to publish that dermatologists are in the vanguard of diagnosing early psoriatic arthritis because the skin complaint tends to precede the joint problems. And so that's why we feel dermatologists are so well placed to be asking the questions and need to have good insight into how psoriatic arthritis may present. And indeed, although my title here is there's a lack of appreciation of each other's specialty, because I think there is, at the guideline level, there's guidelines in England, and there's the signed guidelines in Scotland. There's then the British Society of Rheumatology guidelines done in conjunction with dermatology. The BAD dermatologist guidelines on biologic interventions talk about psoriatic arthritis. These have just been updated from 2009. We've just got a new one published now in the British Journal of Dermatology in 2017. And all of these different guidelines, some of them come from government, some of them come from associations linked to rheumatology, and some from dermatology. All of them say that dermatologists and rheumatologists should be working closely together. For example, NICE, and I was involved in these guidelines in 2012, we should be offering an annual assessment for psoriatic arthritis to people with any type of psoriasis, especially in the first 10 years after the diagnosis of psoriasis has been made, because that seems to be the sort of more risky time if you're going to develop psoriatic arthritis. Dermatologists should be thinking about using validated tools, such as this thing called PEST, and I'll explain a tiny bit more about that in a second. And as soon as psoriatic arthritis is suspected, referral onto a rheumatologist is needed. If you go to Scotland, the same kind of publication from the Scottish Intercollegiate Guidelines as well. So just coming back to PEST, the PEST is something that the rheumatologist designed, because they were basically saying to us dermatologists, listen guys, you're trained and you're very good in managing skin complaints, but you know not a lot about joints. So we need to give you some help. And so what they've done is they designed a questionnaire, very simple, that you give to patients, and if somebody ticks more than 3 of these as a positive, scores 3 to 5, then it suggests there is a joint problem of some sort. How sensitive it is, i.e. how specific it is, it's not that specific, so it's not nailing it down to psoriatic arthritis very often, but it is actually importantly detecting a joint problem that a rheumatologist could probably help with. And actually, Hector Chinoy and I, who do this combined clinic, have taken this study further, and Hector reckons that 90-odd% of people who came to him with 3 or more ticked on this, he could help them in one way or the other, even if it was, for example, physiotherapy and exercise rehabilitation for wear and tear, as opposed to altering their treatment for their psoriatic arthritis. So that's the screening that is recommended uniformly for all dermatologists. But unfortunately, that doesn't necessarily happen. And the general way in a hospital between dermatology and rheumatology, the way the interactions occur is paper-based communications, or you bump into someone in a corridor. Saw a patient, needed to ask you about this. It's very ad hoc, and if it's going via paper communication, then of course the NHS has massive demands. Secretaries sometimes typing 5 days, 10 days, 15 days, a letter goes out, and then the secretary replies from the rheumatologist, and suddenly a month's gone by before you've made any steps forward. So there's often delays in correspondence, and as I alluded to before, there are different treatments that if we thought someone had psoriatic arthritis, we might modify how we would treat someone rather than just being purely focused on what we're used to managing. So, in 2009-2010, myself and a colleague, Dr. Chinoy, put a proposal to the hospital I work, Salford Royal Foundation Trust. And we're a tertiary centre, so we're not just taking referrals from GPs for skin disease and joint disease, we're taking referrals from other colleagues. So it tends to be a more complicated clinic. And we were able to state that whichever guideline you looked at, every single guideline was fully on board with the fact there should be better communication between specialties. And I get on very well with Hector, that's quite important, and we have a very good working relationship, and we were keen to learn more about each other's practice. And of course, everybody in the clinic who had insight into this was telling us that, why on earth have you just written to him and then he's written back and it's only 6 weeks later we're making a change? You know, what, that's not really good enough. And they're right. So Salford's response was, well, give us a demonstration of how this might look. How would it work? What are you planning to do? Cost it. That's always a challenge. And audit it. If we give you the green light, we want to know that this clinic makes a difference. So we gave Salford several real-life examples and said, look, there's a patient of ours, had psoriasis for over 20 years in psoriasis clinic. He's probably seen a rheumatologist decades ago and may or may not have had a confirmed diagnosis of psoriatic arthritis. But generally, in the notes, it seems to be consistently saying this patient has gout. Now, this patient was struggling. Her skin got bad, her joints flared, and it was assumed that this may be a flare of gout. She was actually on a drug, a biologic drug, an anti-TNF drug, that in theory should work for psoriatic arthritis as well as for psoriasis, but sometimes these drugs stop working for one component of the disease but not the other. And she also had some renal issues and was admitted under a renal team. They assumed she had gout. They gave her some steroids, and the steroids, when she came off the steroids, made her psoriasis flare, which is a common thing we see with people whose psoriasis is a little unstable. Steroids can be good in the short term, but if given by mouth and suddenly withdrawn, can cause then a flare of disease. And so this patient needed admitting to settle things down. Rheumatologists eventually saw her during the first admission. She was in for 10 days. During a second admission, she was in for over a month. The rheumatologist saw her, said, this isn't gout, actually, we've done the investigations, this is psoriatic arthritis. The biologic you're using is working for the skin but no longer working for the joints, and we need to make a change. And she then had follow-up in both service settings. And so what we presented was an alternative scenario, that the skin was bad, she was struggling with her joints, and although the dermatologist may have felt that this was a flare of gout, if we had a true combined clinic where we could discuss the treatment, she could be seen in that, remove the label of gout. As that anti-TNF biologic drug was failing one, we could discuss then the best option moving forward. And in this scenario, potentially, theoretically, two admissions with 49 days in total could have been saved. In terms of the old model, we were arguing that there's specialist consultants and specialist nurses working in a once-weekly psoriasis clinic. The same scenario in a once-weekly psoriatic arthritis clinic. And between 10 and maybe actually 20% of patients are going to both intermittently. One appointment, another appointment, another appointment, another appointment. And so over a period of time, if someone's got both diseases, there's an awful lot of appointments going on. If we had the once-monthly joint clinic, we can have consultants who specialise and have ideas across both domains, as can the nurses, and this can rationalise the number of appointments needed and make more efficient treatment decisions. So this was the sort of kind of ideal model that we were proposing to Salford Royal. But of course there's different ways of delivering that care, and Salford made us think about this because we wanted to do a true combined clinic with the pros of patient-centred care, discussion of every case. We would really truly avoid delays in treatment. There was cross-speciality examination and discussions, and from a professional perspective, working in a tough environment that the NHS really is these days, actually working with a colleague that you get on well with and you really feel you're making a difference can be one of the most rewarding experiences, actually. Whereas the other scenarios were, could we have some sort of virtual clinic and improve the paper-based communications, or could we have a parallel clinic where instead of dermatology being in part A of the hospital and rheumatology part B, we'd have myself in one clinic and a rheumatologist running separate lists, but if we needed to talk, we could get up and talk. And we pushed very, very hard for the latter, but of course it has the downside of the huge amount of cost of having two consultants seeing a small number of patients, and hospitals don't like that very much. But we managed to get around that to establish our service in 2010. And we felt that there was a lot of added quality. We were following guidelines, and of course we were requested to do some audits around proving improved care. And we were arguing that it was hard to prove, but it may be cost neutral, although it was expensive having both of us in one room at the same time. The number of inpatient admissions we could save and the efficiency in communication would make it worthwhile. So our paradigm, if you like, was that if a dermatologist was struggling with some sort of joint issue, they refer in to the combined clinic. We stabilise that individual and get a clear management plan, and if the skin is the major problem, the dermatologist take care. If the joints are the major problem, back to the rheumatologist. But they stay in the combined clinic for 1 or 2 visits until we have a very clear plan. And the same scenario for rheumatologists struggling to manage the skin disease. Is it psoriasis? Is it another problem, etc.? The first audit we did, we published at the annual meeting of the British Association of Dermatologists. So we needed to be a bit careful with this because at the same time we also have a very important individual service for psoriasis and individual service for psoriatic arthritis. So what we didn't want to do was belittle those services at all. But for every single consecutive patient, 45 of them across 7 clinics, we just asked them, in comparison, given your problems, i.e. you have problems on both domains, how have you found this service between what you would have expected in the old service? And it was an extensive survey, but the critical thing was people out of 5 generally gave the combined clinic 4.92, which was a very in terms of satisfaction and the fact that this service was designed in the right way. So in terms of the combined clinic, we feel that it definitely speeds up care. It means that often the right therapeutic option is at least offered to somebody to think about whether that's what they want to take or not. Communication is very effective, and actually, importantly in today's NHS as well, having an MDT, there's lots of MDTs for anyone with skin cancer, and we all have to discuss it between different specialists to make sure we're making the right decisions. But MDTs for inflammatory problems aren't as common. But actually, it's easy for one individual to sometimes think, this is the way to go, but you discuss it, and then you might come to a different consensus. So in effect, we have a little mini MDT around each patient to make sure we're making and offering absolutely the right choices. I guess the other thing is as well, because the clinics aren't quite so busy, because the patients tend to be complicated, there is a bit more of an opportunity to spend time, improve communication, but also teach and also deliver on high-quality research. And our outcomes so far, this is a picture of Dr. Chinoy, who I work with. So the trust are happy. We believe the patients are happier, and we have done the audit on that. I have a great working relationship with Hector. And as I said, in tough times in the NHS, I find this clinic probably the most satisfying clinic I do. We've had one PhD student. A PhD student, as you'll have heard from Effie this morning, that's a 3-year undertaking. And because we do this clinic together, we've had one PhD student who's looked at mechanisms by which certain drugs start to fail. And she's completed her PhD, and her PhD application was a direct result of us working together. We've educated loads of medical students, and actually we've now, sorry, I should have put this on here, we believe there are 3 to 4 other clinics modelled directly on our clinic now set up around the UK. And we're currently going to advert for a new clinical research specialist nurse who will be trained in skin disease management and joint disease management to act across the interface and improve things even more. Obviously, I'm very biased, though, I must say. But I think it's worked very well. So I'd like to just give you a few updates now on some research. I was asked to touch briefly on BADBIR, briefly on PSORT. Just before I go into this, because I appreciate some of my slides, and I apologise, I was working on these yesterday afternoon, evening, and even a glass of wine was involved towards the end of this. So Lord knows what's happened at the end of the talk. But is everybody, broadly speaking, familiar with BADBIR and what BADBIR is trying to deliver? No? Okay, fine. So BADBIR does not mean... I didn't have beer last night, I had wine, but it's not bad beer. It's the British Association of Dermatologists Biologics Intervention Registry. Is everybody familiar with biologics as a potential treatment for people with very significant psoriasis? So the biologics have been around since about 2005, 2006, and now we're a decade into monitoring them. And what BADBIR's job is, at the University of Manchester, we get data on each patient who goes onto these drugs of how well they do. Is it working? And importantly, we're monitoring safety. Are people stopping because of side effect X? Are people stopping because of side effect Y? Okay, so it's one of the largest, what we call pharmacovigilance exercises ever run in dermatology. And most people going on a biologic in the UK are filling in data sheets that contribute to BADBIR. We've now got 14,000 patients who've been entered onto this register. And it's not just for patients on biologics. What we're doing is we're comparing that data against patients who are going on to the traditional systemic drugs, methotrexate and cyclosporin, and we're able to then compare the safety between the biologics and the safety of the traditional drugs. And BADBIR, which is supported by Psoriasis Association, British Association of Dermatologists and numerous stakeholders, is now starting 10 years on to inform clinical guidelines. And you remember I said the biologic guidelines for the BAD, the British Association of Dermatologists, have just been updated. And I got an email a week ago and they've gone online, and so they're available now. The guidelines I showed you before included the BAD biologic guidelines from 2009. And in 2009, a drug called ustekinumab was featuring as a second-line drug. In the new iteration of the guidelines, ustekinumab is now featuring as a first-line drug. The anti-TNF drugs, which is another class, are still available as a first-line drug. And then this new drug was being offered as a first-line drug. The wording not quite so strong because it's very new and we don't have as much safety data on it. But the important bit was, why has ustekinumab changed from a second-line drug in the guidelines now to being considered as a first-line drug? And this is from data from BADBIR, where we looked at the persistence, i.e. how long does an individual given this drug stay on this drug. We weren't looking at how efficacious they were or how safe they were, but we were looking at persistence as a surrogate marker of how good they are and how safe they are, on the basis that if you're having a terrible time on a drug, you stop it. If a drug doesn't work, you stop it. So within BADBIR, we were able to look at this longitudinally over a period of time. So we did something called a survival analysis on 3 biologics that fit into this class called anti-TNFs, and those were known as etanercept, infliximab and adalimumab. And we were able to compare it against the persistence of ustekinumab. We looked at reasons why people stopped the drugs, and we tried to find predictors of why people were stopping the drug as well. At the time of the analysis, and this analysis was done a little while ago, but the analysis has specifically informed the guidelines, which is why I'm visiting it today, we had 3,500 patients who were eligible for that particular study. And this graph is the important critical graph that led to the change. So what you can see is the red line here is the persistence of ustekinumab. These little black dots are what we call censoring. So that's each time a patient, you get a bit of data on that patient to prove when they've stopped the drug. So that's all just ignore the black lines. The important thing is the red line for ustekinumab separates versus the yellow line, which is a drug called adalimumab. And then if you look at etanercept and infliximab, people on those drugs are stopping a lot more. So by year 3, 50% of people have stopped etanercept or infliximab. But if you just took the trial data, infliximab has the highest response rate, but yet it has a much higher attrition rate, probably because there's all sorts of reasons for that. But ustekinumab clearly is better than the others in terms of persistence. And so we were able to take that forward to the British Association of Dermatologists and say, look, from BADBIR, we've shown that, we didn't know this, but we've shown that although the drugs seem similar in percentage rates at week 12 or week 16, by year 3, the curves are separating and people seem to be staying on this drug more. Therefore, we should promote it from being a second-line drug up to a first-line drug. Now, the possible reasons for this are important to understand as well. It might be that ustekinumab is just the most effective drug. That's one possibility. But I suspect it's mainly because ustekinumab, interestingly, is a drug that's only given every 3 months. And a nurse is able to come and support a patient and give them the injection. It's given as an injection every 3 months. Whereas those other drugs are given much more frequently and patients learn to give the injection themselves. And giving an injection yourself is, I hear from some patients, it's potentially very daunting and people sometimes miss a dose because they're not quite sure if they should take it, if they've got a bit of a cough or a cold. But if a nurse comes along and can reassure you and then give the injection, the adherence, i.e. people then accepting and taking it, is a lot higher. So that might also be an important reason. But the take-home message is that this very important study that I alluded to when my slides were going wrong at the very start, i.e. supporting safety data, is also supporting and enhancing guidelines as well. So moving on to SORT now. I'm assuming if you've not that familiar with BADBIR, you'll be even less familiar with SORT. So SORT is an acronym, and it is a large medical research council funded academic study and industry collaboration. And actually the total amount of funding that we've got, and SORT is led by my colleague Chris Griffiths in Manchester. He's the chief investigator, and I'm leading one of 2 work strands. I'm leading this work strand here, the clinical and pharmacology work strand. And we've got £7 million of funding to try and work out which biologic we should give to which patient first, or to look for predictors of biologic response. So when we think about different reasons why people may respond, you've heard from Effie today about the importance of genetics. So is your genetics linked to how you respond to a drug? So that's in there. But is it more simple than that? Is there something just to do with the type of psoriasis you've got? Is it the fact that it's thin psoriasis rather than thick? Is it the fact it's on your scalp rather than the buttocks? Is it something simple like that we're missing that might be a clinical factor that drives treatment response? So SORT is trying to look at all of these things, and at the end of it is potentially trying to integrate all of the key little facets so that when you add them all together, you have a true stratifier or a true reason to be able to predict one outcome over another. But the data that we can present at the moment, the first bit is the clinical and pharmacology bit. And the reason we can present the clinical first is because we were able to use BADBIR as a launch pad to get some of this data. And we asked the hypothesis, are clinical or demographic factors predicting biologic treatment response? So hopefully I've explained by clinical and demographic, I'm meaning age, age of onset of disease, body weight, type of psoriasis, site of psoriasis, all of these kinds of things. As I said, we were able to use BADBIR, the data from BADBIR, and patients, when they register onto BADBIR, we know the severity of the disease at the start, and then every 6 months for 5 years we get a snapshot again of how are they doing, any problems, how's the disease behaving. Just to reiterate, within BADBIR we're looking at different what we call phenotypes. So that's types of psoriasis. Is it large? Is it small? Is it thin? Is it thick? Whereabouts is it? What are the comorbid conditions? Does that influence how somebody gets on as well? If you've got hypertension, for example, does that lead to a worse outcome for some reason? So what we did was we took all of the different baseline variables in BADBIR, and then we looked at a group of people 6 months down the line, and we looked at those who stayed on the drug and did really well, achieving something called a PASI 90, which means really your skin's nearly clear, versus those who didn't achieve that. And we looked at the frequency of these different variables in what we call a univariate analysis. And then we took anything that was close to statistical significance, so that means it might be important. We built that into a model to try and prove that independently that variable is still important, and that's called a multivariate model. I barely understand these things myself. I hope you're following me to an extent. In terms of the cohort, it was a data cut from 2015. There was 7,000 patients in the biologic cohort, and we were interested in looking at it at specific drugs. And the main drugs we took forward were adalimumab, because we had lots of people on it, etanercept, because we had lots of people on it, and ustekinumab, which was a newer-ish drug, but an increasing number of patients on it. In total, we were able to analyse 2,000 patients on their first ever biologic and look at predictors for people doing well on their first ever biologic. We found that body mass index, so if you were overweight, you tended to do badly. That makes a lot of sense, and that, to be honest, was already known. But interestingly, we also found that if you had hypertension, you tended to do badly. Now that was a little bit more difficult to explain, but this was just on the first run through that we call the univariate analysis. So we had to then look and see if each of these factors stood up alone in the multivariate analysis. Unfortunately, we didn't find any difference between site of psoriasis or thickness or the different phenotypes, which we hoped we might do. We didn't find that. Then we did this multivariate analysis, and importantly, body mass index and hypertension stayed significant. So they are important variables in predicting you won't do as well on a biologic. Smoking also came out as being a predictor of poor treatment response as well. But none of the different phenotypes seem to predict things. Now, the amount of difference these are making clinically is not massive, so that you wouldn't distinguish which drug an individual should go on based on these findings. But if you remember, the objectives of SORT are much bigger than just this clinical element. They build in the pharmacology element and then the genetic element, and we hope that we might ultimately be able to add a little bit of this one, and this one, and then we will have a true predictive model for working out which drug suits individuals best. So in summary, BMI, hypertension, smoking are predictors of poor clinical response. These data reinforce the kind of lifestyle advice that's important as well. I know from Carla and Helen, people may have questions on comorbidities linked to psoriasis, etc. But I think this reinforces from a treatment perspective as well. It's also important to manage these variables as best we can. But alone, unfortunately, these things aren't strong enough predictors on which we would base a drug decision at the moment. It's getting very warm in here. Is everybody still with me and okay? I've got one more section, and I wanted to touch on a drug called Methotrexate. So has everybody here heard of Methotrexate? Okay, we're on a real winner here now. This is great. So Methotrexate is actually a drug. So I've been involved in a study called the METOP study, which was a 52-week study looking at Methotrexate, the first 16 weeks of which was placebo-controlled. So therefore, patients didn't know whether they were getting the active drug or Methotrexate. But importantly, it was given as an injection. So it was given subcutaneously, like the biologics, rather than by mouth, which is the traditional way that we give Methotrexate. Methotrexate is normally given, well, it is given once a week. And so basically the patients attended and either had a dummy or the Methotrexate. We also started at a lot higher dose than we would normally do. Methotrexate was a drug that was first used by this gentleman called Sidney Farber, and Sidney Farber was an oncologist, so he treated patients who had cancer. And Methotrexate is what we call a folate antagonist, and we all need folate to allow our cells to grow. If you get depleted folate, things like hair loss happen. Now, I don't have folic acid depletion, I've just got male pattern baldness. But fast cells that are growing very, very quickly can quickly get depleted of folate, which is why, in all seriousness, in cancer, when you give cancer drugs, hair falls out because the hair follicle is a rapidly growing cell. But in psoriasis, Methotrexate doesn't work in that way. It works in a much different way. And the doses given for psoriasis are not going to do anything like that by and large. Okay, so it's very, very different. But he was using Methotrexate in the treatment of childhood leukemia. But two gentlemen, Edmondson and Guy, noticed some positive effects in patients who were receiving that treatment for a cancer of some sort. They also had psoriasis, and their psoriasis was clearing. So they then took forward a program of work to try and demonstrate in psoriasis how Methotrexate may be useful. And this was one where we actually beat the rheumatologists who only started using Methotrexate routinely in the 70s. So why were we keen to study Methotrexate? Well, actually, Methotrexate is the most commonly prescribed drug worldwide if you are going to receive a systemic drug for psoriasis. It's very cheap. In the United Kingdom, Methotrexate is £55 per year per patient. The biologics are approximately $10,000 per year per patient. But by and large, most of the evidence is anecdotal. There's very little really good data that Methotrexate works. We know it works, but the problem is you can't sit there and say, oh, I've seen it work, because you can get caught out unless you do a proper randomised controlled trial across a population of people. So there had been 2 randomised controlled trials, only 2. When you think of the biologics, there are loads of trials on them. And the RCTs in Methotrexate were of oral Methotrexate, and the only reason they were done was because the companies that make the biologics wanted to show the biologics were better than Methotrexate. So that was the only reason they were ever done. And only one of those RCTs assessed Methotrexate over 52 weeks. And of course, psoriasis isn't something that, for most people, unfortunately, it isn't something that will just come and then go. This is something that is an ongoing challenge that you need to manage over a longer period of time. And importantly, the only ever randomised controlled trial looking at psoriatic arthritis hadn't sadly shown any benefit for Methotrexate. I think it was because it was a poorly designed study that took a long time to recruit to, rather than the drug doesn't work. In Manchester, we'd done a study that had shown people who'd had oral Methotrexate, who'd gone on to the injectable form, which was available but had never been studied much, seemed to do a bit better. A third of people who'd failed oral then went on and gained some benefit when they went on to the subcutaneous Methotrexate. And we know that this thing called the bioavailability, that means the amount of drug that gets into your body, is better if it's given like that. And potentially, Methotrexate causes about 20% of people a lot of tummy pains and makes people feel sick. If you give it as an injection, there's some evidence that that doesn't happen. We also wanted to understand, and I don't present this data, but we wanted to understand a bit more about the mechanism of action. You know, I was mentioning it's not working by being a folate antagonist. We don't quite know how it does work, but it's definitely not through that mechanism. So we also did some mechanistic studies, and I don't present that data, I present the clinical data, but that was another motivation to do this study. So we did an investigator-initiated study across Europe, and I mentioned Christian Wright before. Christian and I wrote the protocol for this, and normally randomized controlled trials these days are run by multi-billion dollar companies that have about 20 people assigned to do this kind of thing. And there was just the two of us sat in a pub in Hamburg writing a protocol, trying to get it right. By the way, I don't do all my inspirational work when I'm drinking, just so we're clear on that. So we set up this 52-week study. It was relatively modest in terms of patient numbers. You had to have a certain severity of psoriasis, and that was this thing called the PASI, or body surface area over 10%, which tends to be usually the kind of cut-off at which point people are offered these kind of drugs. And methotrexate was then compared against placebo for the first 16 weeks. Normally, we give a low dose and we titrate it up. We were keen to understand that if you gave a higher dose, A, was it safe? Did it cause any more problems? And B, did it lead to a quicker response? Because we feel a lot of people give up on this drug because it takes so long to work. The placebo patients crossed over at week 16 and then went on to the active drug, and that's what you call the post-blind period, which means that everybody's now aware what they're taking and what they're on, including the investigators and the patients. This thing that we call the primary endpoint, and this is important, that before you do a study, you have to say, this is what we want to prove, because then no one can come back and say, you're just looking at the data until you've found something. You say, this is what we're trying to do. So the primary endpoint was week 16, and this thing called the PASI. Is everyone familiar with PASI? No. So the PASI is the way the dermatologist will try and assess the severity of psoriasis. So it takes into account the amount of coverage over your body, how red it is, because there's different gradations of how red, and the more red, the more inflamed, how scaly it is, because the more scaly, the more active the disease, and then how thick the plaques are. And it's on a scale of 0 to 72, but over 10 actually means you've got significant psoriasis. And so what we do is we set a baseline, and then we look at 16 weeks to see how much the PASI's gone down. And if you've achieved a 75% reduction in your baseline, that's your PASI 75. So I'm sorry, I should have added a whole load more explanatory slides, so I'm sorry for that. We were then interested in quality of life, which we measure as the DLQI, and if it's a 0 or 1, it tends to suggest, at least in the previous week, the psoriasis isn't having too much impact. PASI 90, which is a higher bar, i.e. you've got a 90% reduction, and then some other outcomes at week 52. But this was our main goal, to show it worked at week 16. So this is then a graph. This is week 4, week 8, week 16, and you can see here that there is always a placebo response in a trial. The placebo response was around 8%, but methotrexate was working in just over 40% of people by week 16, which is actually similar to oral methotrexate. Now, we're not comparing it against oral directly, but if you looked at the oral studies, this showed a similar kind of efficacy. So when we looked at that data, we were like, it's not actually an awful lot better, really. But when we looked at week 52, 45% of people were still achieving a PASI 75, which for this drug we felt was still pretty good. Now, this is where it gets complicated, and I already alluded to the fact I'm not a statistician, but I do understand enough about statistics to know that you can present data in different ways, and it can make it look more or less positive. So what we wanted to do was we took a type of analysis called a non-responder imputation, and that is the most conservative way we can present the data. So that is, if Mr. Smith is taking methotrexate and he goes, do you know what, I don't want to do your study, but I'm doing well, but I don't want to do it, he's counted as a non-responder. And if Mrs. Jones says, I'm moving, I can't do this study for you anymore, I was doing wonderfully well, but I'm moving to Southend, Mrs. Jones is counted as a non-responder. So when you look at week 52, that's a non-responder imputation. So that means the drug is actually still doing pretty well, considering the type of analysis we've applied. And actually the only other data we can compare against with oral methotrexate showed that methotrexate's in blue here, and methotrexate was being compared against a biologic drug in this particular study. At the primary endpoint, roughly 40% of people were doing well. But look at 1 year, only 23% of people, when it was analysed as a non-responder imputation, were doing well on the drug, which seemed to give us a suggestion that giving it as an injection is potentially better than oral. Now, the reason I say potentially is these are two separate trials done in different, potentially, countries and slightly different populations. So we can't be sure without doing a head-to-head study between subcutaneous and oral. But you can imagine, to do a blinded study, people would have to be taking dummy oral drugs and having dummy injections, while some people have real injections and some take real. So it's a hard study to do. And also, because the results are similar at week 16, when you do the statistics to show that one is more beneficial than the other, you'd have to do a massive study to show that potential small difference, or you'd have to do a really big study over 52 weeks to show that difference. And because this was initiated by us, and we don't have that kind of funding at the moment to do this study, that's why it was designed the way it was. So, for all of the caveats of comparing across trials, and hopefully I've been fair about that, 52-week PASI 75 with sub-Q methotrexate is 45%, but with oral methotrexate it's only 23%. So we met the primary endpoint, but this was the important point at week 52. And actually, we've just had this data accepted in the Lancet, which is tough to get data into the Lancet. It's actually one of the more difficult journals to get things in. And I think it's because of the 52-week data, that's where I think people think that potentially this has broad implications, not just in the UK, but worldwide, because this drug is relatively cheap. And maybe people would be better served with considering this as an injectable treatment. So it's the most widely used systemic drug for psoriasis. It's also of great interest to rheumatologists and gastroenterologists. And as I said and reiterated, the overall efficacy is very, very good at week 52. So just to summarise today, the first points we were making was there's a great need to improve communication and interaction between dermatology and rheumatology. We believe that of the different models, the virtual model or parallel clinics versus a combined clinic, we believe that the combined clinic is ideal. It may be that that's not appropriate for absolutely every centre. It might be that different models need to apply in different centres. But the Psoriasis Association can undoubtedly help to drive such initiatives and to push for such initiatives, because I think it is important to improve the awareness of both specialties. We discussed BADBIR, that isn't BADBIR at all. It's the Pharmacovigilance Safety Registry, and it's now informing, importantly, the data from it is informing the UK biologic guidelines. And that PSORT, which is the stratification programme funded by the Medical Research Council, is in the early stages, but some clinical factors do influence drug responses, but probably not enough at the minute by themselves. And then consideration to injectable methotrexate is also worthwhile. I can honestly say thank you very much for inviting me today. It has been a real honour to present to you all. I hope you've been able to follow it, and I really hope that the motorway's like that on my way home. Thank you very much.